Hi students, and welcome to 66 Adult Health 2 Module 6. Moving good for you for showing up for yourself and being here, especially for you auditory learners. It's really important to actually hear the lecture, even though it's the same stuff you'll read in your book. So I'm proud of you for showing up. You guys were all going to be amazing, wonderful nurses. Okay, chapter 49. We're going to talk about endocrine problems. So endocrine, some people get a little scared off by endocrine. It is one of my very favorite topics. I love it so much because I think it's just super interesting. So hyperthyroidism. I remember way back when, long time ago when I was in nursing school, I remember my endocrine lecture and I remember almost nothing. Okay, I'm like 53, I'm old, I don't remember things. But I remember this lecture about hyperthyroidism, and they talked about a lady who had just given birth, and she was at home, and someone was going to do like a well visit after she was home, and they knocked on the door, and she answered, and she was wearing a tank top, and she was going really fast, and she was sort of thin and sweaty, and the house was cold and the baby was cold. And it was about, that's the picture of a hyperthyroid person, and I've never forgotten it. And so my point of the story is you just have to remember, picture people that have these different disorders, and you will never forget them. It's not that hard. So there's a continuum of thyroid dysfunction. So the fancy word for hyperthyroidism is thyroid toxicosis. That's the end of the pendulum is swung all the way over here. And then there's hyperthyroidism. Euthyroid means your thyroid is doing nothing. Excuse me. And then hypothyroidism, and then myxedema coma is hypothyroidism. So myxedema is another name for hypothyroidism. Coma is the worst, where thyroid toxicosis is the worst. So you think about remembering which one. So toxicosis is like if you are at toxic levels of something, that's you have too much. The coma is you have too little, right? So that's the way to remember the ends of the spectrum. So hyperthyroidism is a sustained, not just a one-time thing, a sustained increase in the synthesis and release of thyroid hormones by the thyroid gland. You have too much thyroid. It occurs most often in women, mostly between the ages of 20 and 40. The most common form is called Graves' disease. Other causes, other than Graves' disease, could be a toxic nodular goiter, thyroiditis, which is inflammation of the thyroid, which could be caused from so many things, excess iodine intake. So somebody's has salt with iodine or other foods with iodine, high iodine foods that they have a lot of intake of, or sometimes people would take supplements with iodine not knowing that they're going to produce too much thyroid. Pituitary tumors, and then thyroid cancer. So how do you get Graves' disease? So Graves' disease is an autoimmune disorder where your body attacks itself, autoimmune. So it's your own immune system that isn't doing its job. You have diffuse thyroid enlargement, excess thyroid hormone secretion. And remember, your thyroid is right here. Can you guys see it in the camera? It's right here, sort of like a butterfly shape. And there's different lobes of your thyroid. So there are causative factors that interact with genetic factors that cause Graves' disease. So women are 5 times more likely than men to develop Graves' disease. The clinical manifestations, or that's the fancy way to say, what does it look like? What are the cues? So it looks like these are related to the effect of having the excess thyroid hormone. Increased metabolism, so the lady that answered the door, she's going a mile a minute. Increased tissue sensitivity to sympathetic nervous system stimulation. Goiter, you might actually see that their neck is swollen. This is the one where when you're at the doctor, they put your hands on your neck and they say swallow, because you should not feel your thyroid, and if you do, there's something wrong. So you might also auscultate and hear a bruit. Ophthalmopathy, so they have enlarged eyes. And so I don't know if you guys have seen those commercials with, bulging eye disease. That also can be from the thyroid. That's exophthalmos. So that's where there's increased fat deposits and fluid, and it forces the eyeballs outward. So it looks like their eyes are just bigger. Here, I'm going to show you right here, like that. Only even worse most of the time. So that is exophthalmos and a goiter. So you see her neck? That's a goiter. Here's the problem. Once you're a nurse, you're a nursing student, you can't even go to a grocery line at a grocery store without seeing things that are wrong with people. It's sort of a curse. Okay, so what are our other clinical manifestations or signs and symptoms? So cardiovascular, they will have systolic hypertension, a bounding rapid pulse. Remember the lady, you knock on her door, she has a baby, it's cold, she's going, 90 miles an hour. Palpitations. Because of the bounding rapid pulse, they have an increased cardiac output. So cardiac output, that left ventricle, squeeze, squeeze, squeeze. And so if it's bounding, it's like, the contractility is increased and the rate is increased, you are going to have more cardiac output, right? It's like a math equation. You can't not have more cardiac output. And they could, palpitations because it's just going so fast. Cardiac hypertrophy, systolic murmurs, dysrhythmias, angina. For the respiratory system, they might get dyspneic on mild exertion or have an increased respiratory rate. In GI, they're going to be hungry, thirsty, but yet they're going to have weight loss, diarrhea, splenomegaly, hepatomegaly. The skin, warm, smooth, moist skin, thin, brittle nails, hair loss, clubbing of fingers, maybe palmar erythema, fancy word for saying their palms are red. Fine, silky hair, premature graying in men, diaphoresis, vitiligo. Intolerance to heat, like I said, the lady's freezing, right? The baby's freezing, the lady's hot. Elevated basal temperature, a lid lag or a stare, eyelid retraction, and rapid speech. The treatment. So they can have radioactive iodine that is given. So you'll have a patient that has radioactive things and you have to stay away from them. This is where you make sure you plan your care accordingly to only be in there for a few minutes. So if they have radioactive iodine, you have to be sure to teach patients that there will be symptoms of hypothyroidism when the radiation treatment is completed, because it kills, it doesn't know just to kill it a little bit, it kills the thyroid. So medications are the hallmark treatment, and medications may take time to work, so possibly several months for a full effect. And so they're going to be dealing with symptoms of all sorts of thyroid problems, because they started with all these symptoms of having hyperthyroid, but now kill the thyroid, they have no thyroid, and so now they feel like they're hypothyroid. They give meds to replace the thyroid, like Synthroid, synthetic thyroid, Synthroid, and it takes a minute. So it's very frustrating, and they're not fun symptoms. So this is acropatchy. So musculoskeletal, we're still going. Fatigue, weak, proximal muscle wasting, dependent edema, osteoporosis. For the nervous system, hyperactive, deep tendon reflexes. So what we're noticing for this hyperthyroid is everything's up, up, up. Hyperactive reflexes, heart rate that's up, talking too fast, weight gain. So just this, think of everything sped up. Nervousness, insomnia, difficulty focusing, lability of mood, delirium, lack of ability to concentrate, stupor, coma. Coma is the end. Reproductive, menstrual irregularities, amenorrhea, decreased libido, decreased fertility, and impotence and gynecomastia in men. So acute thyrotoxicosis, that's like, remember the pendulum squeeze, that's as high as you can get. So this is called a thyroid storm. So think of a thyroid storm. If you're like, if you're like on your NCLEX and thinking, wait a second, thyroid storm, is that too high or too low? Is a storm ever low? A storm is too much, right? It's called a storm. So it's excessive amounts of hormones released. It is a life-threatening emergency. Death is rare when the treatment is started early. It results from stressors. So somebody is hyperthyroid and now they're stressed out and they get thyroid storm. Thyroidectomy for patients at risk. What does this look like? What are the manifestations or the cues that you need to recognize as their wonderful, smart nurse? Severe tachycardia, heart failure, shock, hyperthermia like up to 106. Can you imagine? Agitated, seizures, abdominal pain, vomiting, diarrhea, delirium, and coma. And so when we test them, they're going to have a decreased TSH, less than 0.4. Increased free thyroxine. Total T3 and T4 is not definitive, and they're going to end up with radioactive iodine uptake. So, okay, you're like, why? Let's go back. Why is the TSH decreased if they have too much thyroid? Because a decreased TSH is a thyroid stimulating hormone. If your body has way too much thyroid, your thyroid doesn't need to stimulate, right? It's like every other smart organ in your body. Think about your pancreas. If you have way too much insulin, your pancreas is not going to produce insulin. It knows. You know, the thing with the fluid system, everything in your body knows what it's doing. So your thyroid, you know, looks around with its binoculars and sees a bunch of thyroid and says, I'm on break today. Decreased TSH, decreased thyroid stimulating hormone. So let me just jump ahead while I'm on this. If you have hypothyroid, you're going to have an increased TSH. And don't be confused, because your thyroid's looking around with the binoculars and it doesn't see any thyroid. So let's push out some extra thyroid stimulating hormone to try to get the numbers up. So hyperthyroid will have a low TSH. Hypothyroid will have a high TSH. So it's confusing until you understand. Now it's not confusing. This is why I say it's better to understand concepts than try to just have rote memorization, because there's too much in nursing to have it that way. You need to understand. So what are our goals for this person that is a hyperthyroid? We want to block adverse effects of thyroid hormones, suppress hormone oversecretion, prevent complications. So the treatment options are antithyroid meds, iodine therapy, or surgery. Drug therapy is useful when they're in this like thyroid toxic state. Things that are not considered curative, but they are useful, would be antithyroid meds, iodine, and sometimes B adrenergic blockers like Inderol will provide a quick result. Here's some other ones. Tapazole inhibits thyroid hormone synthesis. There's an improvement in 1 to 2 weeks. Results are usually seen within 4 to 8 weeks, and the therapy is 6 months to 15 months. So iodine. So this could be potassium iodine and Lugol solution. This inhibits the synthesis of T3 and T4 and blocks their release into circulation, hence not so much thyroid. It decreases the vascularity of the thyroid gland, making surgery safer and easier. Maximum effect is 1 to 2 weeks. So maybe somebody will be on this prior to surgery, sort of like the cancer patient that has radiation to shrink the tumor before they have surgery. Same thing. They're going to do this to sort of have a safer surgery. B adrenergic blockers, so like the Inderol, symptomatic relief of thyroid toxicosis. It blocks the effects of the sympathetic nervous system, which decreases the cues, clinical manifestations of tachy, nervous, irritable, tremors. So that would be Inderol or tenormin. Propranolol, atenolol are beta blockers with OLOL. Radioactive iodine therapy. So this is the treatment of choice if they're not pregnant. It damages or destroys that thyroid tissue. It has a delayed response of up to 3 months. We're going to treat with antithyroid drugs and beta blockers before and during the 3 months of iodine. Given outpatient. For patient teaching, we want to make sure they have good oral care, radiation precautions, and watch for the symptoms of hypothyroidism. For surgery, it's going to be indicated if they have a large goiter. Imagine, you know, you can't just have a big thing here, because what happens behind there? Breathing. So you can't have if you have a large goiter that compresses the thyroid, the trachea, you have to do something about that. So one of the indications for surgery, if there's a large goiter causing tracheal compression, if they are unresponsive to antithyroid therapy, if they have thyroid cancer, or if they're not a candidate for radiation. It will induce rapid reduction in T3 and T4. A subtotal thyroidectomy is the preferred surgical procedure. It removes 90% of the thyroid. It can be done using minimally invasive procedure like endoscopy or robotic surgery. Like this. Nutrition therapy. So they need a high-calorie diet, 6 full meals a day with snacks in between. Protein intake should be 1 to 2 grams per kilogram. Ideally, increased carbs. Avoid highly seasoned and high-fiber foods and caffeine, and they definitely will need a dietitian. So for nursing, we're going to look at their past medical history. Do they have a goiter, recent infection, trauma, immigration from an iodine-deficient area, autoimmune disease? We're going to look at their meds, family, iodine intake, weight loss, about their appetite, nausea, vomiting, diarrhea, polyuria, sweating, all the things. We're going to look at, do they have dyspnea on exertion, palpitations, muscle weakness, fatigue, insomnia, chest pain, nervous, heat, decreased libido, impotence, gynecomastia, amenorrhea, emotional emotional lability. Let me try to say it 4 more times. Irritable, restless, personality changes, all the things. Objectively, they might be agitated, rapid speech, not just because they're trying to record a lecture in less than an hour. Anxiety, restless, hyperthermia, enlarged or nodular thyroid gland, exophthalmos, the eyes, eyelid retraction, infrequent blinking, warm, diaphoretic, thin, loose nails, fine silky hair, palmar erythema, clubbing, vitiligo, and edema. We're going to continue, but we already talked about these, so I'm not going to read this list to you, but all the things that we talked about in clinical manifestations are going to be the things you're going to note on the nursing assessment. For diagnosis, it could be activity intolerance, impaired nutritional status, and lack of knowledge. Preoperative. So, of course, you're going to give meds to achieve a euthyroid state. You're going to give the iodine to decrease the vascularity to make for a safer operation. We're going to teach them about comfort and safety, leg exercises, head support, and neck range of motion. If you're having surgery right here, we have to be careful that you don't go crazy with your neck and have bleeding. And they're going to have routine post-op care, which includes, we're going to monitor for complications. So what are some complications if you take out the thyroid or part of the thyroid? You're going to have hypothyroidism. That's sort of expected. Hypocalcemia, hemorrhage, laryngeal nerve damage. That's one of those like sign off that you might have laryngeal nerve damage and you hope you don't have it. Thyroid toxicosis, infection. We're going to maintain the airway. So in the room, you have to have oxygen, a suction tray, suction equipment, and a trach tray ready, just in case. If there is all of a sudden so much swelling that they can't breathe, they're going to have an emergency tracheotomy, and you don't want to be like, hey, Susie Q, go find a trach tray. They won't make it. So if it's a post-op for a trach removal, for a thyroid removal, you have to have a trach tray at the bedside all the time. We're going to want to monitor for laryngeal stridor, so that's like that really graty sound. Like if you have a really old rocking chair and you're rocking, that's what it sounds like. That's laryngeal stridor. IV calcium readily available in case of an emergency. Watch for neck swelling and report immediately if it worsens. You're not going to be like, oh, it's getting a little swollen, let's see what happens. No, that's an emergency because that's their airway. Airway is an emergency. Okay, also assess frequently during the first 24 hours for hemorrhage and tracheal compression. They're going to be in semi-Fowler's position. You're not going to lay these people flat. We want gravity to help. Support the head with pillows. Avoid tension on that suture line. You know, you're not going to have them do this, right? Monitor their vitals. Look for signs of hypocalcemia. Ambulate, and then give them psychosocial support. For discharge, you're going to want to monitor their hormone balance periodically. Make sure that there's somebody who is going to come to their appointments to have their labs drawn and everything. Decrease their calories. Adequate but not excessive iodine, just normal iodine. Regular exercise. Avoid high environmental temperatures. Regular follow-up. And for complete thyroidectomy, they're going to look for symptoms of hypothyroidism and a need for lifelong thyroid hormone replacement. That's why they try to do the subtotal thyroidectomy to leave a little bit of function, so they don't have to, completely replace all the thyroid. So what are we going to do? We want them to have a relief of symptoms, no serious complications, cooperate with their pain, and maintain their nutrition. Okay, hypo. Let's talk about the other end. So hypothyroidism is a deficiency. It causes a general slowing. So everything we talked about in hyper, we're going to look at the opposite, and that's hypo. Slowing metabolic rate, still more common in women than men. They're going to have, so subclinical hypothyroidism is a TSH greater than 4.5. That thyroid is at work. It is working hard to try to pump out more thyroid. That is the thyroid stimulating hormone. So the body says, hey, you, stimulate some, and because it's low. The T4 levels will be normal, and this affects up to 10% of women over 60. So it's not quite hypothyroidism, but they're getting there. Non-thyroidal illness syndrome. This is critically ill patients that have low T3, T4, and TSH. So what is the etiology and pathology? So primary hypothyroidism is caused by destruction of thyroid tissue or a defective hormone synthesis. Secondary hypothyroid. Okay, so remember, We've learned this in every area we talk about. Primary is, that's the beginning. It starts with the thyroid. Secondary is, the thyroid is affected, but something else caused it. When we talk about primary tumors, then there's secondary tumors. Primary, anything with the heart, with the lungs, there's is it the primary or is it secondary caused from something else? So secondary hypothyroidism is caused by pituitary disease, either decreased TSH or hypothalamic dysfunction or decreased TRH. Iodine deficiency, atrophy of the gland from Hashimoto's thyroiditis, which is inflammation of the thyroid, or Graves' disease. We're going to treat for hyperthyroidism. One of the causes is treatment for hyperthyroidism. They overdo it, or the patient doesn't take it right, and now they're hypothyroid. Could be from drugs, cretinism, if it occurs in infants. So the systemic effects are characterized by slow body process. This person, you're sitting there, okay, you go in the house, you're dying of heat, the person's overweight, their skin is dry, they're slow, they're tired, it's hot, all the things, okay? So everything is slow. Tired, lethargic, impaired memory, low initiative, weight gain. Cardiovascular can be significant, especially if they have cardiovascular problems, because they have decreased cardiac contractility. So where we talked about before, the heart's like the decreased output, decreased contractility, increased serum cholesterol and triglycerides, and anemia. They have low exercise tolerance, right? They want to be hot, slow, their heart's not acting right, they're overweight, shortness of breath, they're fatigued, lethargic, personality, mood changes, impaired memory, slowed speech, decreased initiative, somnolence, decreased appetite, nausea, vomiting, weight gain, constipation. Hyper has diarrhea. These people, everything slows down. Constipation, distended abdomen from the constipation, enlarged scaly tongue, and even celiac disease. Integumentary, they'll have dry, thick, cold skin, thick, brittle nails, dry hair, poor turgor of the mucosa, edema, puffy face, decreased sweating, pale, fatigue, weak, muscle aches, pains, slow movements, arthralgia, prolonged menstrual periods, decreased libido, and infertility. This is somebody that has really bad hypothyroidism. That's mixed edema. So mixed edema, think edema, swelling. Okay, that's how you remember that that's hypo. The complications of mixed edema coma, there can be precipitated by infection, drugs, cold, or trauma. It's characterized by impaired consciousness, subnormal temperature, hypotension, hypoventilation, cardiovascular collapse, treated with IV thyroid hormone. So diagnostically, we're going to look at the history and physical, TSH and free T4. So the TSH increases with primary hypo, TSH decreases with secondary hypo. So do make that distinction. Thyroid antibodies, we're going to look at cholesterol, triglycerides, CKs, and red blood cells. So what do we want to do? We want to restore euthyroid state as safely, as rapidly as possible. They will get hormone therapy, a low-calorie diet. They're going to take Synthroid. It's also called levothyroxine. They're going to start with a low dose. Monitor for chest pain, weight loss, nervousness, tremors, insomnia. They're going to increase the dose every 4 to 6 weeks until the TSH is normal. And that means that your body has enough, because the thyroid stimulating hormone can chill out and not have to stimulate so much. It is lifelong. They'll need labs lifelong to make sure their dose is right. So history, these are all, I won't go over this. These are all the things that we just talked about. These are all the things that we're going to see in their history and in their physical exam. Cold intolerance, constipated, depressed, decreased heart rate. Okay? Activity intolerance, constipated, impaired nutritional status, and lack of knowledge. We want them to have a relief of their symptoms, maintain a euthyroid state, have a positive self-image, and adhere with lifelong thyroid therapy, or they'll feel horrible. So it's sort of a motivator. So to assess for a risk, most prevalent in female, white ethnicity, advancing age, type 1 diabetes, Down syndrome, family history, goiter, previous hyperthyroidism, previous radiation treatment of any sort. Because if radiation hits the thyroid, that's a problem. High-risk population should be screened. Most is outpatient. I mean, it's a lot of information, and so it's best to give them written instructions. Mixed edema coma needs acute care. They're going to need to be on mechanical ventilation, monitoring their heart, IV thyroid replacement, and monitoring of their core temperature. Teaching, they need written instructions, a need for lifelong therapy. They cannot stop the drug immediately. Side effects of medication, they need to check their pulse. Signs and symptoms of hypo and hyperthyroidism, regular follow-up. Do not switch brands. That's a big deal. You can't switch pharmacies and you have a new brand. Medication interactions, to have a comfortable, warm environment. Measurements to prevent skin breakdown. Avoid sedatives or use the lowest dose possible. Measures to minimize constipation. Relapses occur if treatment is interrupted. But a big deal for them to check their pulse for safety. Okay, Addison's disease. So primary is Addison's disease. This is a reduction of glucocorticoids, mineralocorticoids, and androgens. Secondary would be lack of pituitary ACTH, lack of glucocorticoids and androgens. So 80% of cases are caused by an autoimmune response. So autoimmune adrenalitis, inflammation of the adrenal glands. Antibodies destroy the adrenal cortex, and you have a loss of glucocorticoids, mineralocorticoids, adrenal androgen hormones. So autoimmune polyglandular syndrome is a co-occurring endocrine condition with type 1 diabetes, autoimmune thyroid disease, pernicious anemia, and celiac disease, and it is most common in white females. Yikes, I went too fast. TB, not common cause in the United States, but getting worse all the time. Amyloidosis, fungal infections, AIDS, metastatic cancer, iatrogenic Addison's disease from adrenal hemorrhage, from anticoagulants, chemo, ketoconazole therapy for AIDS, or a bilateral adrenalectomy. So what does this look like? And if they have an insidious onset, it's going to be anorexia, nausea, weak, fatigue, and weight loss, which could be anything, right? I mean, you could have the flu and have anorexia, nausea, weak, fatigue, and weight loss. It often advances before it's diagnosed because those are really vague symptoms. You don't go to the doctor for those symptoms. I'm a little nauseous and I'm tired and I've lost weight. First of all, I'm not going to go to the doctor if I lose weight. I'm going to be jumping up and down for joy, right? So these are not things that are a big deal. Abdominal pain, diarrhea, headache, orthostatic hypotension, salt craving, and joint pain. Again, women my age, this is common in women. My joints hurt. I sometimes get dizzy when I stand up. I like salt, and I have headaches sometimes. You know, I mean, these are just so general, these symptoms. Now, this is not general. This hyperpigmentation, that might make you think something is wrong. So the complications, how do you know if something is really bad? So this Addisonian crisis is where you have an acute adrenal insufficiency. This is an insufficient or sudden sharp decrease in hormones. It is a life-threatening emergency, and there are various triggers. So the manifestations of glucocorticoid and mineralocorticoid deficiencies would be hypotensive, tachy, dehydrated, low sodium, high potassium, high glucose, fever, weak, confused, vomiting, severe vomiting, diarrhea, pain. Shock may cause circulatory collapse. So now, this is what I'm talking about. Once you have these symptoms, something is wrong, but that's why it is rarely diagnosed until it gets much worse. Because those vague symptoms, nobody's running to the doctor for that. What are we going to do to look at this? We're going to look at an ACTH stimulation test. And so this looks at the baseline levels of cortisol and ACTH. IV injection of synthetic ACTH given. The levels are rechecked after 30 and 60 minutes. So an elevated blood cortisol level is normal. Little or no increase in cortisol levels in Addison disease. High ACTH level in primary adrenal insufficiency. So for a CRH stimulation test, an abnormal ACTH test response, IV injection of synthetic CRH, blood drawn after 30 and 60 minutes with high ACTH levels with no cortisol indicates Addison disease. Absence of the ACTH or delayed response common in the secondary adrenal insufficiency. So these are all the labs or tests we're going to look at. So there's the labs, EKG, and then CT scan and MRI. Interprofessional, they're going to be on lifelong hormone therapy with hydrocortisone. And if they have increased stress, they need to keep hydrocortisone on them. It's an emergency. You have to have your adrenals work right. Florinef, and women need androgen replacement, and they also need to increase their dietary salt intake. So for nursing implementation, we're going to want to monitor them, look at their fluid and electrolytes, assess their vitals, their neurologic status, daily weights, accurate eyes and nose, look at their medication history, and watch for signs of Cushing's syndrome. So patient teaching, we're going to report signs and symptoms of corticosteroid deficiency and excess to their healthcare provider. They need to carry identification because hydrocortisone, they could need hydrocortisone as an emergency treatment. And they need to wear a medical ID bracelet, have an emergency kit with IM hydrocortisone, with written instructions. The glucocorticoids is in divided doses, mineral corticoids is once in the morning, reflects the normal circadian rhythms, and decreases the side effects of corticosteroids. And during stress, they need to increase the doses. So acutely, we need to guard against infection, assist with their daily hygiene, protect from extremes of light, noise, and temperature. So for the corticosteroid therapy, it is effective in treating many diseases and disorders, but there are complications and side effects with long-term use. The potential benefits are weighed against risk. Like when I was a hospice nurse, I would have people who were on hospice for COPD and could not breathe, and they would be bedridden at home with less than 6 months or less to live, and they would take steroids every day and it would help them breathe. And they didn't care if their face got puffy or maybe it hurt their adrenal glands because they were dying. Different. That's where your potential benefit outweighs the risk. But if you have a 23-year-old, totally different situation. Okay, so expected effects of corticosteroid therapy are anti-inflammatory effect. It's really good for anti-inflammatory, for it's immunosuppressive, and it maintains a normal blood pressure. So what are the side effects? Decreased potassium and calcium, increased glucose and blood pressure, delayed healing, susceptible to infection, suppresses the immune response, so they wouldn't have a fever maybe, problem. You wouldn't know they have an infection. Peptic ulcer disease, muscle atrophy, mood and behavior changes, moon face and truncal obesity, protein depletion, and a risk for acute adrenal crisis if it's stopped abruptly. So what do they need? Dietary, rest, exercise needs, sodium restriction if they have edema. They need to monitor their blood sugar, notify if they have epigastric pain. They need to try to prevent injury and infection, inform all their healthcare providers, and they need therapies to reduce osteoporosis. Okay, now we have the opposite of Addison's, which is Cushing's syndrome and hyperaldosteronism. So this is caused by an excess of corticosteroids. And so we were just talking about what happens if you need all these corticosteroids. Well, here's what happens. You have too many corticosteroids and you get Cushing's syndrome. The common causes are iatrogenic, I can never say that word, administration of exogenous corticosteroids, ACTH secreting pituitary adenoma, which is a tumor, adrenal tumors, ectopic ACT production by tumors. So a lot of tumors or just taking way too many steroids. This is Cushing's syndrome. So you think of like a cushion. That's how you remember a Cushing. What is Cushing's syndrome? Think of a cushion, big, puffy cushion. Okay, here's what it looks like. Thinning of their hair, red cheeks, acne, moon face, buffalo hump in their back, supraclavicular fat pad, like right here, like weirdly, increased body, facial hair, weight gain, purple striae on their belly. Their abdomen will be larger. They could have bruises from easy bruising, thin extremities with muscle wasting, thin skin and subcutaneous tissue, and slow wound healing, like this. So clinical manifestations with excess glucocorticoids, they're going to be hypoglycemic related to glucose intolerance and increased gluconeogenesis, muscle wasting, loss of bone causing osteoporosis and back pain, loss of collagen causes thin skin, easily bruising, delayed in wound healing. Mineral corticoid excess may cause hypokalemia, hypertension. Adrenal androgen excess may cause severe acne, male characteristics in women, and feminization in men. Diagnostically, we're going to confirm increased plasma cortisol levels with midnight or late night salivary cortisol. We're going to look at the saliva. It's the best test. Low-dose dexamethasone suppression test. 24-hour urine cortisol and the levels greater than 100 micrograms over 24 hours. We're going to look at the urine levels of 17 ketosteroids that might be high. For plasma ACTH levels, high or normal with Cushing disease, if the pituitary is the problem. Low, normal, or high with Cushing syndrome. Hypokalemia and alkalosis with ectopic ACT syndrome and adrenal cancer. So what are we going to do? We're going to normalize their hormone secretion. The treatment depends on the cause. So they might need to surgically remove or use radiation on that pituitary adenoma. Adrenalectomy, if they have an adrenal tumor or hyperplasia, tell the patient that most of the appearances will go away after surgery, because all those things that we just talked about, people don't want to look that way or struggle, and tell them, hey, after surgery, we're going to remove the tumor. Once we remove the cause of all those symptoms, your appearance should go back to normal. We're going to remove that ACTH secreting hormone. If it's prolonged, if the cause is prolonged use of corticosteroids, gradually discontinue their therapy. Not overnight. Don't do that. Never, ever, ever let somebody stop their steroids. Right? You have to wean off of them. Decrease the dose and convert to an alternate day dosing. And the dose must be tapered gradually. So I won't read everything here, but this is the pituitary. So patient history. We're going to look at everything related to the pituitary. Corticosteroids. All the things we just talked about, wound healing, bruising, headache, joint pain, amenorrhea, impotence, all the things. Objectively, these are all the things that we just talked about in that picture, with the fat pads and the thin hair and friable skin, acne, bruising, striae. Cushing syndrome, decreased potassium, decreased glucose, dyslipidemia, polycythemia, granulocytosis, lymphocytopenia, eosinopenia, all these a ton of different lab problems. So what are our nursing diagnoses? They're at risk for infection, impaired nutrition, disturbed body image, impaired tissue integrity, and a lack of knowledge. So for planning, the patient goals are to have a relief of symptoms, avoid serious complications, maintain a positive self-image, and actively take part in a therapeutic plan. Health promotion, we want to identify those at risk for Cushing syndrome. Long-term exogenous cortisol therapy is a major risk factor. Teach patients about medication use and to monitor for side effects. Acutely, we're going to monitor vital signs, weight, and glucose. We're going to assess for signs and symptoms of inflammation and VTE. Emotionally, they might feel unattractive, unwanted. We're going to be very sensitive to their feelings and respectful. Reassure them that these things will resolve. Preoperatively, we want to optimize their physical condition, control their hypertension and hyperglycemia, correct their hypokalemia, high protein diet to correct those protein stores that are depleted, and it depends on the surgical approach what they're going to do. So their nursing post-op, they have an increased risk of hemorrhage. Large release of hormones into the circulation causes instability in their blood pressure, fluid balance, and electrolytes. High doses of corticosteroids are given IV during and for several days after surgery. They have an increased risk for problems with glycemic control, infection, delayed wound healing. We need to report any changes in vitals and monitor their fluids, give corticosteroids as ordered, and obtain morning urine samples for cortisol measurement. Nursing, we're going to also look for acute adrenal insufficiency, which would look like vomiting, weak, dehydrated, hypotensive, painful joints, itchy, peeling skin, severe emotional problems. Bed rest until blood pressure is stabilized, monitoring for subtle signs of infection, and meticulous care to prevent infection. For Cushing syndrome, ambulatory, they're going to need a home health nurse. They're going to need a medical alert bracelet. Avoid exposure to extreme temperatures, infection, and stress. Teach them how to adjust their meds and when to call their doctor, and know that it's going to be a lifetime of replacement therapy. Acromegaly is a rare condition in which the body produces too much growth hormone, causing the body tissues and bones to grow quickly. You might see somebody that says, why do my shoes not fit all of a sudden on assessment? Because they have acromegaly. Parathyroid, there's a lot of endocrine issues, and so these are just the main ones. Parathyroid issues, and so with hypoparathyroid issues, you may need calcium supplements to normalize their hormones. If there's a tumor, treatment is often a parathyroidectomy, which is radical neck surgery, and post-op they might have tingling lips and carpopedal spasm, and so you're going to have them breathe into a paper bag. Okay, this is all from your books. I hope you have a wonderful week. Thank you so much.